Hello everyone, welcome to today's webinar, Applications of Fluorescence-Guided Imaging in Gynecologic Surgery. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of your control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. It is my pleasure to introduce your speaker, Dr. Andrea Papadia. Dr. Papadia is currently Professor and Director of the Department of Obstetrics and Gynecology of the Ente Ospedaliero Cantonale, Ospedale Regionale di Lugano, Università della Svizzera Italiana in Lugano, Switzerland. His research interest covers various themes of gynecologic oncology with specific interest in the field of sentinel lymph node mapping in uterine cancers and fluorescence-guided surgery. Over to you, Dr. Papadia.
Thank you very much for the kind presentation. It is my pleasure to give this talk via webinar for the Society of Fluorescence-Guided Surgery, which I think is a very nice society that I've been joining for a few years by now. So today we will talk about the applications of fluorescence-guided surgery in gynecology. And these first, a couple of informations about ICG. Indocyanine green, which is the dye which is involved mainly in fluorescence-guided surgery, was first developed in 1955 by Kodak Research Laboratories for developing photography. Only later was approved for clinical use and mainly involved in angiography. And the peculiarity of this dye is that it becomes fluorescent when elicited in a light which is in the near infrared spectrum. Now, in gynecology, we have a couple of applications. The most important one and the most relevant one is in gynecological oncology and especially in surgical staging. However, the use of this type of surgery is growing. The interest towards this surgery is growing, and some other applications are being studied, mainly in endometriosis. So we'll go over these topics. Mainly, we'll talk about the surgical staging, and then we'll talk a little bit about the endometriosis application. Well, when we talk about surgical staging, we mainly the application of ICG has been very relevant for the development of a sentinel lymph node concept in uterine cancer. Uterine cancer involves both the cervix, so cervical cancer, and the uterine corpus, so endometrial cancer. And lymph nodal staging, surgical staging, is very relevant in both cases because lymph nodal involvement has a very bad prognostic factor. Here you see this is an historical data from the surgical pathological study performed by Delgado from GOG back in the 1990s, where you can see that basically the higher risk factors where the survival is very badly influenced is basically because of lymph nodal involvement. And we know by now that if lymph nodes are involved in cervical cancer, you rather treat the patient with chemoradiation rather than with surgery. So it is very important to identify these patients with positive lymph nodes in order to avoid a major surgery on them. For endometrial cancer, the topic of surgical staging is way more controversial. And similarly, back in the end of the 80s, a similar study as the one performed by Delgado in cervical cancer showed that lymph nodal involvement is not that uncommon in endometrial cancer. But then for some reason, full surgical staging has always been questioned in endometrial cancer and has never become completely a routine treatment in every case. However, we know that knowing the lymph nodal status is very important in endometrial cancer as well, because it may help reducing and tailoring the adjuvant treatment. If we know that the pathological status of the lymph nodes is negative, especially for high risk or high intermediate and high risk patients with endometrial cancer, this may reduce the indication to an adjuvant treatment with radiotherapy. Here on the left-hand side, you see the classification of the high, intermediate risk endometrial cancer and high risk endometrial cancer, the way they were defined back in 2016 and how they were defined recently in 2021, which is basically some little changes. Either way, knowing the pathological lymph nodal status of these patients has an impact on the way we treat them adjuvantly. And also, it is very important also to point out that when we know that the lymph nodes are negative, well, then we know that the patients will have a better survival. But most importantly, we know that if the lymph nodal status is unknown, then we will have a worse survival of this group of patients as compared to those where we know that the lymph node is positive. This is basically to underline how important it is, even for endometrial cancer, to know the lymph nodal status, as it may help tailor the adjuvant treatment and therefore improve survival ultimately. However, to perform this staging for cervical cancer, we basically need a full pelvic lymphadenectomy. For endometrial cancer, we need a full pelvic lymphadenectomy and full para-aortic lymphadenectomy. Now, these are surgeries which are relatively large, which involve a large dissection, anatomic dissection, as you can see. They require a long learning curve, and they may be associated with a significant number of intraoperative and post-operative complications, such as vessel injuries, nerve injuries, and lymphatic complications. As you can see, I mean, a full dissection is really something that in a case like this may take up to 3 or 4 hours in when the surgery is performed by a skilled physician. And we'll just skip to the next slide. However, sometimes this surgery not only is demanding from a point of view of a surgeon, but sometimes even not really feasible. This is a CT scan of a patient with endometrial cancer, who theoretically should be submitted to a full pelvic and para-aortic lymphadenectomy. However, in such an abdomen, it's really very difficult to perform this full lymphadenectomy. Also, considering that this is just a staging procedure, not really something that is therapeutic. So in this background, the concept of sentinel lymph node mapping becomes really important, because if we can substitute a full lymphadenectomy with just a simple removal of few selected lymph nodes, and then we can analyze these lymph nodes in depth, then we move somehow the intensity of a staging from the OR to the pathology lab. Okay, and this reduces the risk of complication and the morbidity of the procedure to the patient. Now you see here the 3 major dyes that are used for sentinel lymph node mapping, which is technetium 99, blue dyes, different types of blue dyes, and ICG green. And this is basically an image of a surgery for sentinel lymph node mapping in uterine cancer after injection of the blue dye. And as you can see, we see the dye flows through the lymphatics, and these can be seen and can be identified, and therefore the lymph node can be selectively excised. More complicated when we inject the technetium, because the technetium is colorless. After the injection of the technetium, we perform either a scintigraphy or ideally we would perform a SPECT scan, which is more helpful in identifying the location of the lymph node. However, when we then perform the surgery, this is a little bit more complicated because we're going to need a gamma probe that goes through one of the ancillary trocars in the laparoscopy, and we'll have to operate with only 2 other instruments, identifying a lymph node that just gives an audiometric signal and not a visual signal. On the contrary, using ICG, and this is the column that I use, but there are many devices that work very well, all of them, is very intuitive and very simple. And you just basically need a camera which is able to elicit with a near infrared light the dye, and a camera that can elaborate the signal, giving a fluorescent signal. And oops, excuse me. And this is how a sentinel lymph node mapping works. So this is a patient with endometrial cancer, which was injected in the cervix with ICG, and as you can see, we shrink the optic, and by shrinking the optic, we increase the intensity of the signal, and all of a sudden the uterus becomes blue. It used to be completely dark, the whole thing. Now, this specific patient is a patient with endometrial cancer I operated on, and she has a BMI of 35. We then start the blunt, gentle dissection in the retroperitoneum, and that's something that needs to be performed carefully in order not to disrupt all the lymphatic vessels, because otherwise you may stop the lymphatic drainage of the dye, or if you disrupt too many lymphatics, then you might stain the entire field with the dye, and then the detection becomes a little bit more complicated and difficult. But as you can see, even in a patient which is defined as morbidly obese, we can really follow easily the lymphatic vessel that runs along the axis of the uterine artery to identify one single sentinel lymph node, which is located in the obturator fossa, which is the typical location of the sentinel lymph nodes in this case of surgery. And this simple surgery, as you can see here, this is a thinner patient. You can also see through the peritoneum the signal, but through this simple excision, we basically substitute such a big and large excision. And this is very useful because by reducing the extent of the surgery, we do reduce the morbidity. We published recently this study on over 200 patients who underwent surgery for endometrial cancer, and some of them did not undergo any kind of lymphadenectomy. Some of them underwent a sentinel lymph node mapping, and some of them underwent a full surgical staging, either with pelvic or pelvic and paraortic lymphadenectomy. As you can see, the time, the amount of the estimated blood loss and the time of surgery of the patients who did not undergo any kind of staging and those who underwent sentinel lymph node mapping are very similar, and they're both lower, significantly lower than those as compared to those of patients who underwent a full surgical staging. Now, how does this work? Well, it seems to work very well. This is one of our first studies, a retrospective validation study on 75 patients who underwent a full pelvic and paraortic lymphadenectomy after having performed a sentinel lymph node mapping in endometrial cancer. And we found, first of all, that the detection rate, so the number of lymph node, number of patients in whom we identified the sentinel lymph node was very high. Not only the detection rate was high, but also the bilateral detection rate. So finding lymph nodes on both sides of the pelvis is something that works very well. 88% of the patients had bilateral lymph nodes, which we identified. In our hands, the false negative rate calculated on this cohort of patients was 8%, which is relatively good and compares well with the data presented by the Memorial Sloan Kettering Cancer Center, where the false negative rate of a sentinel lymph node mapping performed with different dyes, not only with ICG, was 15% and was reduced to 2% when a sentinel lymph node mapping algorithm was applied, which entails basically the excision of all mapped sentinel lymph nodes, which undergo another staging, which means a thorough pathological analysis with immunohistochemistry. And additionally, any suspicious node needs to be removed regardless of the mapping. Additionally, if one side of the pelvis did not map, then a site-specific lymphadenectomy needs to be performed. In this case, the false negative rate can be turned down to almost 2%. These data were confirmed by a prospective study published on The Lancet a couple of years ago, where 350 patients underwent a sentinel lymph node mapping with the sentinel lymph node mapping algorithm and then a full lymphadenectomy. And in the hands of the authors, the false negative rate was comparable to that reported by the Memorial Sloan Kettering Cancer Center series and was around 3%. Now, in this scenario, when we're starting to substitute a full lymphadenectomy with a sentinel lymph node mapping algorithm, it becomes very important to have a high bilateral detection rate in order to reduce the site-specific lymphadenectomies. And we were able to demonstrate both in cervical cancer patients and in endometrial cancer patients that the use of ICG allowed for a significantly higher bilateral detection rate of the sentinel lymph nodes as compared to a blue dye or technetium. And this becomes very, very important in the idea of the sentinel lymph node mapping algorithm. We were able also to confirm this data in this meta-analysis that we wrote back in 2016. Several other meta-analyses have been published later on. All of them confirmed our data that basically ICG performs better than the other dyes when we're talking about sentinel lymph node mapping in uterine cancers. Not only does it perform better, but it's also perceived as a better quality of care by the patients, because when we performed a sentinel lymph node mapping with technetium, we need to inject the technetium the day before the surgery. We need to perform a scintigraphy, or a SPECT scan on the day prior to the surgery, and then perform the surgery afterwards. With ICG, we inject directly the dye in the OR at the time of the surgery, and this is leaner and perceived as a better quality of care by the patient. Lastly, a prospective randomized trial compared ICG with blue dye in uterine cancer, confirming the data of the retrospective studies that we published earlier on, showing that ICG has a better detection rate, a higher bilateral detection rate than blue dye. And this is true especially and also in patients with high BMI, where basically the performance of the blue dye drops very quickly because we don't see the color anymore, but it does drop, but only but way more slowly when we use ICG. And I showed you a nice video about it, because the fluorescence of the dye basically increases. It's like having a dye on steroids, basically increases the visibility of a signal. Okay. This specific technique really gave a big push to the concept of a sentinel lymph node mapping in endometrial and cervical cancer. And the sentinel lymph node mapping is now recognized by the major guidelines as a good alternative to a standard lymphadenectomy in endometrial cancer. And this is something that without the user friendliness and the power of the ICG of the fluorescence would have probably not been the case. Here you see where we typically inject the dye. It can be either in 2 points or in 4 quadrants, and that's really up to you on how you can feel comfortable and how it works in your hands. And here you see the two most common lymphatic pathways that are relevant for the staging here in uterine cancer. What we saw before was a lymph node in this area. Now, ICG is typically given for angiography and in other scenarios ID, and we really inject to an interstitial injection, and some questions are on which dose should be used and how this should be injected and so on and so forth. And there's not really a good answer to it. What we know, and this is very well shown by a meta-analysis which is dated in 2014, and as you see here, various different type of cancers were included in this meta-analysis, and different concentrations and volumes were used. But basically what you see here, that the higher diagnostic odds ratio is obtained for concentrations which are lower than 5 milligram per milliliter. So you don't want to use a concentration which is too high, and for volumes that are above 2 milliliters. So you probably don't want to use volumes that are too low. Now, we did we did try to answer the question which is the best dose in our scenarios, and we compared two different schedules in two universities that work very similarly otherwise. And we basically compared the different concentration and tried to correlate it with the bilateral detection rate, which using a higher concentration did not improve the detection rate. What it did improve was the number of lymph nodes retrieved. So this is not very much different what was shown by other scientists like Person and others, who were able to show that by increasing the volume of ICG injected, a higher bilateral detection rate of both lymphatic pathways could be determined. Okay, so if you really want to see both pathways on each side, then you may want to use a somewhat higher amount of volume. This is really how it looks like in reality. This is a typical aspect of a uterine cancer that is undergoing a sentinel lymph node mapping with ICG. Now, it works so well that sometimes it even works too well. So remember that it stains a lot, and sometimes you may think that you're removing a lymph node, but you're actually removing some tissue which is stained as well. So that's the concept of the empty nodes that are detected in up to 8% of the patients with endometrial cancer, and this may affect your appropriate staging. So if you're in doubt whether you have removed a node or just some lymphatic tissue, you may want to check that with your pathologist by doing a frozen section. Okay, one other way, another way we have used ICG is in this case report we published a few years ago on JMIG, and this is a patient who underwent a full lymphadenectomy and then developed a lymphocyte, basically. Developed a lymphocyte. So the lymphocyte also caused the dehiscence of a vaginal vault. So we had to take the patient back to the OR to close the vaginal wall, the vaginal cuff, I'm sorry. And at that time, prior to the surgery, we injected 3 milliliters of ICG between the toes, and then we're able to identify, as you can see in figure 2 here on your right-hand side of the screen, where the leakage of lymph was, and then we're able to suture it. We also put some fibrin sealant on top of that, and that was able to stop the lymphatic fistula. And this is mainly the major field, or the most important field where ICG or fluorescence surgery is the most developed in gynecology. Now there's some other fields that are on the way that are so-called work in progress. One of these is endometriosis, which is a benign disease, which can cause infertility and pain, and which is very quite often it's a condition that we often do operate on, and then it becomes very important to remove the entire lesions that we see, the entire endometriosis that we see. Now the endometriotic lesions, they may have a very heterogeneous aspect, but they're all very well vascularized, and these lesions are usually located in various aspects of the pelvis. As you can see here, they determine the stage according to the American Society of Reproductive Medicine, but also they can grow in the rectovaginal septum and some way in the retroperitoneum. So it becomes very important to identify them, and given that these lesions are usually very well vascularized, there's the hypothesis that by giving ICG ID, we might be able to better detect all the lesions and be more radical in our surgeries. And this is work in progress with some studies which have shown inconsistent results. What I'm going to present today is this series of 69 patients which was published recently, and this study was performed at the university I used to work just about 2 years ago, and we were unable basically to show that ICG improves the detection rate of endometriosis. And as you can see here, this is a lesion in the sacrouterine ligament, which has a fluorescent correspondent here on your right-hand side. Now, this is an endometrioma, okay, which an endometrial cyst, which doesn't light up at all. And at last, you see a deep infiltrating endometriosis. So in our hands, the intravenous injection of ICG was not really helpful in improving the detection of the endometriotic lesions. However, it might still be useful in specific scenarios. Sometimes it might be difficult or well, sometimes these lesions are very close to the ureter, and if some surgeons are not very confident with their dissection, they might inject some ICG through the bladder into the ureter, thereby illuminating or showing the ureter in a fluorescent aspect. But most importantly, I think it is important because at times we have to perform some bowel resections, both in endometriosis but also in ovarian cancer patients. And then it becomes very important to make sure that our anastomosis is very well vascularized, that it's not an ischemic anastomosis. And then it becomes important to, well, the ICG or the fluorescence surgery can be very helpful in that. But that has been the topic of other webinars, so I'm not going to get into that. So in conclusions, in gynecology, the fluorescence surgery has made it possible to move from a full lymphadenectomy to a sentinel lymph node mapping as a standard of care in uterine cancer. ICG is definitely the preferred dye, and that is stated very clearly by the major guidelines. In endometriosis, there's still some work in progress, and the results are not all very consistent. However, for bowel anastomosis and uterine visualization, the ICG is definitely something that might be helpful in gynecological surgery as well. Thank you.
Thank you very much, Dr. Papadia. We're now going to begin answering the questions submitted during today's presentation. As a reminder to our attendees, you can still submit questions through the questions pane in your control panel. So our first question for today, Dr. Papadia, is how does ICG perform as compared to the conventional tracers in sentinel lymph node mapping in uterine cancer?
Well, it definitely performs a lot better. It is very easy to use. It has a very safe profile, well, it's very safe to use. There's only very few contraindications to the use of ICG. And as we have seen, it increases the detection rate. It increases the bilateral detection rate. And it's really easy to use, and as a consequence, it is perceived by the patient also as a better quality of care. It makes the whole process a lot leaner, because when you think of the other dyes, basically you have the blue dye, which is very easy to use as well, because you inject it in the surgery at the time of the surgery, but it doesn't perform that well in terms of detection rate. And it is also associated with a higher risk of allergic reactions. And if you compare it to the technetium, well, the technetium needs to be injected most of the time in the nuclear medicine ward. Then the patient needs to be isolated for a while because it's radioactive, basically, compound. And then the patient needs to undergo a scintigraphy or a SPECT scan. And then on the following, and the injection is performed not under anesthesia, so it's uncomfortable for the patient. And then on the following day, you need to look for these lymph nodes with a gamma probe, and it becomes a little bit of a clumsy surgery. It's not really user-friendly. ICG is as simple as injecting the blue dye, but it performs a lot better. It really is like a dye on steroids, because you see it a lot better, even in morbidly obese patients, which is quite often the case when we're talking about endometrial cancer patients.
Thank you very much, Dr. Papadia. Another question for you. Is there a change or, I think, delay in time or negative test in patients with pre-radiotherapy?
That's a very nice, very good question. Well, I can tell you about my experience, and there is. In my experience, we had a couple of, out of these cohorts we published, some of the patients who did not, in whom we did not detect the dye, were pre-irradiated patients. We had 2 patients who had undergone radiotherapy to the pelvis prior to the surgery, sometimes even because of our pathologies years before our surgery. And in those cases, we were not able to detect any lymph nodes, and the ICG did not work. And this is probably related to the fibrosis that is induced by the radiotherapy, because you see, when you inject the dye in the interstitium, then the dye is basically gets into the lymphatic vessels, where it binds to the albumin and then travels to the lymph nodes. And if there is fibrosis in these lymphatic vessels, then the whole lymphatic drainage will be disrupted. And that's, I mean, it's not the reason not to try to perform such a procedure. There's no reason not to do that, but most likely it will not work. In my experience, it has not worked.
Thank you very much for your answer. Our next question, Dr. Papadia, is what are the contraindications to ICG?
Very few, and it's basically it's an allergy to the compound, which is extremely rare. It's extremely rare. So basically, almost everybody can undergo that.
Thank you very much. Another question for you. How does the safety profile of ICG compare to that of other traditional tracers?
Safety profile is very good, is excellent. As I said, the only contraindication is basically knowledge of an allergic reaction, which is extremely rare to that. And that compares very well with the blue dye. The blue dye, for instance, has a very, either if you use methylene blue or patent blue, I mean, these dyes, they do have a significant number of allergic reactions. So each time you inject this dye, and there is a little risk that you may have an allergic reaction. These can be even severe anaphylactic reaction. And that's something that is not, well, that can be a problem, especially if you're considering that you're performing a staging surgery. So it's not basically a therapeutic procedure, but it's just something that will help you determine the management, the oncology. If you're talking about lymphatic mapping, that will help you determine the oncologic management of these patients. Yeah, it's really very safe.
Thank you, Doctor. Another question from our audience. What dose of ICG do you use, and how, when, where do you administer it?
Thank you for the question. Well, when I started, well, when I was working at the University of Bern, we used to use a very high concentration, about 5 milligram per milliliter. And we used to inject basically 8 milliliters in the cervix, both for cervical and endometrial cancer. And that was a dose that was really high compared to the doses reported by other centers, but we felt that in our hands it was working very well, and we just had some problems changing. But then we compared our series with those of some colleagues of ours working in Monza with the series from Dr. Buda. And we saw they use a very smaller dose, 1.25 milligram per milliliter, and very concentration, and also a lower dose. They use 2 milliliters. And we saw that basically the detection rate, the bilateral detection rate, didn't change much. And so we started decreasing our dose. We're still not down to that dose. What I do use right now is, well, I went down to that dose in the meantime, 1.25 milligram per milliliter, but I still do inject a little larger volume. I still inject around 8 milliliters in the 4 quadrants of the cervix, and it's working well. I have a very high bilateral detection rate, so it's really uncommon that I have to perform a site-specific lymphadenectomy. That does really barely ever happen, and I very often see these 2 additional lymph nodes that follow this other lymphatic pathway that runs around the ureter. So I decreased the concentration in order to probably reduce the number of lymph nodes I remove, but I still stick to a relatively large volume. But I think that is, if you compare all the series, they all work very well. So I don't think that there is a strict dose that you need to use. The safety profile is very good, and you can give up to 5 milligram per kilogram of ICG, and that is still not toxic. So find what works for you. This is what works for me, and then I would stick to it.
Thank you very much, Doctor. Unless our attendees will submit some other questions in the next 2 minutes, this is actually our last question. So the question is, where is ICG best injected for sentinel lymph node mapping in uterine malignancies? Thank you.
Thank you. Well, when we're talking about cervical cancer, quite obviously it's the cervix. There's been some debate with regards to the best place to inject ICG for endometrial cancer, which is a cancer of the corpus uterine, and some inject in the cervix, which is very easy, very simple, user-friendly. Some have injected in the inside the uterine cavity, and some have injected in the serosa. These injections do better respect the anatomy of the lymphatic flow, because the corpus of uterus will also have some lymphatic flow to higher levels and will follow the lymphatics along the infundibulopelvic ligaments, for instance. But at the end of the day, studies comparing the two different sites of injection are, and we do ourselves have a prospective study that we just closed, and we're analyzing the data, but they seem all to show that the cervical injection is equivalent to the other one, if not better, because it is user-friendly, it yields a higher bilateral detection rate, and just easier, leaner, and more efficient. So the cervix is the place to inject.
Thank you very much, Dr. Papadia, for answering our attendees' questions today and for your time. So thank you everyone for attending today's webinar. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of International Society of Fluorescence Guided Surgery, with grant funding from Diagnostic Green and our presenters, thank you for joining us today and enjoy the rest of your day.
Thank you.